So hello everybody and welcome back to the podcast. I hope that everybody is doing good. Before we start, just a quick reminder that I do offer doula support and hypnobirthing courses, power hours. I'm also very active over on my Instagram. So if you are interested in any extra support, I will leave a link. I also do have a Patreon page as well where you can get some extra support and like ad-free episodes and early access episodes and bonus episodes and things like that. So I will leave links for those below. And if you do enjoy the podcast, please do share and like and leave a comment and a review. I would be really, really grateful. So today we are going to talk about a topic that I know can feel a little bit loaded and maybe a little bit stressful when you first hear about it in pregnancy. And that is Group B Strep, or GBS as it is commonly known as well. This is something that is often presented in quite a clinical and risk-focused way. And so, understandably, that can leave you feeling worried or fearful. So what I want to do is I want to bring in some context and some perspective to this topic and hopefully help you understand not just what the recommendations are for GBS, but why they exist and what your options really look like. This episode is inspired a lot by the work of Dr Sara Wickhams, particularly her book, Group B Strep Explained, which is known, and she is known for taking a really balanced, evidence-based, non-alarmist approach, which I really like. And, you know, ultimately, that is the right approach, because what we're not trying to do is tell you what to do. We're trying to help you feel informed enough to decide what is right for you yourself. So let's start by understanding what Group B Strep actually is. So Group B Strep, or GBS, is a type of bacteria that lives naturally in the human body. It is most commonly found in the intestines, the rectum, and the vagina. One really important thing that I want you to understand is that it is part of the normal bacterial ecosystem for many people. It isn't an infection in the way that we usually think about infections. It's not something you've done wrong, something that you've caught, or something that necessarily needs treating. In fact, around 20 to 40% of women in the UK carry GBS at any one time. And globally, estimates sit around 10 to 30% of pregnant women. Because GBS comes and goes, you might have it one week and then not the next. And so this is why it's often described as transient. And we'll talk a little bit about why that's important for testing a little bit later. A really important reframe here, and something that Dr. Sara Wickhams talks about in her book, is that we need to stop thinking of GBS as automatically being a problem and start seeing it as a normal variation in human biology, because that is what it is. When something is this common, it can't automatically be seen as dangerous. It has to be understood in context. So how does GBS affect babies? So during labour and birth, GBS can be passed from parent to baby. This usually happens during a vaginal birth through contact with bodily fluids. However, what is often missed when we're kind of discussing this and during these conversations is that most babies who are exposed to GBS do not become unwell. In fact, the vast majority of babies are born healthily and never experience any symptoms at all. In very rare cases, GBS can lead to infection in newborns, and there are two types of infection that are usually discussed and are really important to understand. There is early onset GBS, which occurs within the first 6 days after birth and can lead to conditions such as sepsis, which is a blood infection, or pneumonia. And then there is late onset GBS, which occurs between 7 and 90 days after birth and can include infections like meningitis. The important point here, because the treatment for GBS is usually antibiotics during labour, So it's really important to point out here that antibiotics given during labour do not prevent late onset GBS. So this is something which is often not made clear, and actually I think is really, really important. So if we look at the numbers around GBS, if you carry GBS, around 1 in 1,750 babies will develop a GBS infection. So as a percentage, that 1 in 1,750 babies, so the one baby who will develop a GBS infection, as a percentage is 0.06%. 0.06% of babies, if you carry GBS, will develop an infection. Without antibiotics, the risk of early onset infection is estimated at around 1 in 200 to 400. With antibiotics given during labour, this drops to 1 in 4,000. So you can see antibiotics do reduce the risk, but they are reducing an already very small risk. Looking at the UK more broadly, around 66 babies per month will develop a GBS infection. Most of these babies recover fully. A small number experience long-term complications. This context really matters because when we only hear that GBS can be dangerous, what our brains tend to do is fill in the gap and imagine the worst. So when we understand that the overall risk is small and that most babies are fine, it creates space for calmer and more balanced decision making, which is what we want when we are going into our birth. So let's talk about testing, because this is an area that often raises a lot of questions. In the UK, routine testing for GBS isn't offered. And this can feel a little bit surprising when you first hear this, because a lot of other countries do routinely test for it. Testing, I get it. Like, it can sound appealing because it gives you a clear yes or no answer. It feels proactive and it can seem like a way to reduce uncertainty. However, there are some limitations with testing, and probably the reason why we don't test in the UK. Firstly, GBS is transient. As I said already, you can test positive at 36 weeks and not have it at the time of birth, or test negative at 36 weeks and then have it later. So it means that the results are not definitive. Secondly, testing does not reliably predict which babies will become unwell. Many people who test positive go on to have completely healthy babies, and some people who test negative still have babies who develop infection. Thirdly, testing often leads to a cascade of interventions. A positive result may lead to antibiotics in labour, increased monitoring, and changes to your birth plan. And this can obviously influence not just the clinical side of things, but also how you feel then going into your labour, particularly if that change is quite big. If you'd been planning to be at home and then you needed to then be in the midwifery unit or the hospital. So the deeper question kind of becomes whether more information always leads to better outcomes, or whether sometimes it creates anxiety without significantly improving them. So the treatment, as I said already, typically is antibiotics during labour. So let's talk a little bit about that. So there is a clear benefit, which I've already discussed, which is that intravenous antibiotics given during labour does reduce the risk of early onset GBS infection. So again, just only for early onset GBS infection, it has no effect on late onset GBS. They are most effective though when given at least 4 hours before birth. So we don't know when we're going to give birth. We don't know how long labour is going to take. We don't know when we get to the point where we have 4 hours left. So timing wise, it can get a little bit complicated or potentially even stressful. It could obviously lead to you going into the hospital much sooner just to make sure that you get the antibiotics. But then if you're in hospital quite early, obviously that can lead to further kind of interventions. Hospitals work on timescales and it's a lot more restricted than being at home for the beginning part of your labour. So there are obviously the benefits of antibiotics, but to look at the wider picture, one consideration is the impact on the baby's microbiome. So when a baby is born, they are exposed to and colonized by bacteria from their parent. So the microbiome plays a really crucial role in immune system development, in digestion, and also in long-term health. So antibiotics given during labour can reduce bacterial diversity and alter early gut colonization. Some research has linked disruption of the microbiome to increased risk of allergies, asthma, eczema, and obesity as well. This doesn't mean antibiotics directly causes those conditions, but there is growing evidence of a connection and definitely worth considering. There can also be short-term effects. Babies exposed to antibiotics may be more likely to require additional monitoring. They may experience feeding challenges or may have some early gut disruption as well. Another really important consideration is antibiotic resistance. So on a global level, overuse of antibiotics contributes to antimicrobial resistance, meaning bacteria evolve to resist treatment. This can make infections harder to treat and medical procedures riskier in the future. The World Health Organization has identified this as one of the biggest global health threats. So while one course of antibiotics may feel really small, at a population level, these decisions do add up. So we need to be conscious of them. There are also potential maternal side effects. Although this is uncommon, antibiotics can cause allergic reactions, including rare but serious anaphylaxis, as well as digestive disruptions and thrush as well. So when we put this all together, we can see that there are clear benefits to antibiotics in reducing the risk of early onset GBS, but there are also important considerations, including microbiome impact, the fact that they do not prevent late onset GBS, issues around antibiotic resistance, and also potential side effects. So this is why this topic isn't a straightforward or one size fits all decision. It really is, as with everything in birth, it's a balance of risk and benefits, and different people will come to different conclusions, which is completely fine. So this is where informed decision making is really, really important, and why I create these episodes for you, so that you can have a balanced view and that you can then make an informed choice that's right for you. You might decide that you want antibiotics because you want to reduce that risk as much as possible. You might decide that you feel comfortable with the level of risk and would prefer to avoid antibiotics. Or you might find yourself somewhere in between. It can be helpful to think about your own personal risk factors. So how you feel about medical intervention in labour and what matters most to you. Is that minimising risk as much as possible or minimising intervention? And everyone is going to be different in their level of risk and what is more important to them. Remember that fear tends to thrive in uncertainty, in lack of context, and in one-sided information. We often just get one-sided information from the hospital. So it is so important that you do your research and you listen to both sides. Confidence comes from understanding the full picture and feeling able to make decisions that align with your values. And it's very personal, very individual. There is no right or wrong answer here. It's just what you are happy with doing. If this episode has helped you feel even a little bit calmer or clearer on the subject of GBS, then that's exactly what it was here for. Remember, you don't need to rush this decision and you don't need to get it perfect. You just need to choose what feels right for you with the information that you have. If you would like a deeper dive, I really do recommend reading Group B Strep Explained by Dr Sara Wickhams, which is really reassuring and balanced. And if you found this episode helpful, please do share it with somebody who you think might need it. Please do like, subscribe, review, and I will see you in the next episode.